and they have developed their practice mainly on the TMJ, having referrals from physicians, dentists, and specialists in the mandibular region. So when I asked Levy, okay, well, I'm going to do this presentation mostly and hopefully I can get this presentation more dynamic by showing you some of the video clips that we have, and hopefully being able to, most of you who are viewing this in the comforts of your home can follow through some of the techniques. So I made this as simple as possible. And again, this course, again, as part of my disclosure, is a course that we teach in our diploma in orthopedic manual physical therapy program. So it's an advanced course, which is 2 days, and TMJ is part of the 2-day course, as well as the craniomandibular region. So it's usually very hard to just teach the TMJ on its own as a standalone course, because a lot of the things that we see in the TMJ has to include the cranium and the entire facial system. So as you will see in the next few slides, you'll see what I mean about looking in the TMJ into a regional perspective. I want to make an acknowledgement of part of this course that I developed was mainly in conjunction or in partnership with a dear colleague of mine. Her name's Teresa Caribio. She has been retired from practice now, but when she started, she was actually a clinician that I worked with back 5-6 years ago when she joined the healthcare system outpatient department. And I was very excited because at that time we didn't have any PTs who were specializing in the TMJ. So when she came aboard, she was actually in transition towards retirement, but she wanted to have a few hours of clinical work within our clinic. So we were fortunate enough to have her. And a lot of the doctors too was fortunate to have her and to know that we had TMJ specialists in our rehab department. So I was able to sort of mentor under her, and I want to thank her. Really, maybe half of this course we both developed together. She brought a lot of experience in terms of teaching this course too, way back when she was a young PT in the 80s. So if you could imagine, she's, I think last time I spoke to her, she is fully retired and she lives here. But basically, I've had her, I maintained her as a consultant for PT, Physical Therapy Advancement seminars. So when I brought her in to teach the TMJ back in 2014, and we offered this course locally here, just in Florida. And this was the first course that we actually taught. And I was basically not the main instructor. I was just basically lab assistant, but I was able to follow her in her teaching as well as in the clinics, because we shared patients, and I would come and see her, and we would talk about, we brainstormed a lot with a lot of cases that we saw in the clinic. Although at some point she actually moved to another facility, also within the same healthcare system, but we did communicate a lot through email as far as a lot of the patient cases that we saw. So I thank her for it, and again acknowledging her for her expertise and mentoring under her. At that point, back in 2014, it was also a time where my wife actually had severe bouts of facial pain, and so she helped me navigate through the problem. And I think at this point in time, I thank her for a lot of the advice and a lot of the things that we did in order to help again my wife. in her symptoms of facial pain. And I'll discuss a little bit of that later on, but it wasn't serious. It wasn't a serious thing. She's basically okay now. And I think as part of my sharing my case with you, as well as other cases that I'm going to talk about, I think this is important too for your learning. So learning objectives, we have a few objectives here for you. First, we want to discuss the prevalence of TMJ disorders, prevalence, and a little bit of the anatomy and of the temporal joint, describe the arthrokinematics and biomechanics of the TMJ, outline the components of the patient's history and chief complaint, discuss the examination process of a patient presenting with TMJ and orofacial pain. Also perform select interventions to address symptoms and functional limitations of patients presenting with TMJ disorders. So again, as part of my disclosure, these are a part of the learning objectives of the craniomandibular course that we offer in the as far as on our diploma program. Unfortunately, because it's a lab intensive program, we're not able to offer it yet until hopefully the COVID restrictions are lifted and we can all resume our program. And I appreciate all the emails and the messages we get from in our physical therapy advancement seminars Facebook page, and those PTs who know me from previous courses that we've taught in the OMPT. This is again an advanced course that we are hoping to offer sometime next year, and hoping that we can all travel. All right, so prevalence of TMJ disorders. So what we say when we say prevalence is basically looking at how is TMJ, how is the condition distributed in the population? Okay, where do we see it? What population parameters do we see TMJ disorders or cases mainly? So up to 50 to 75% of the population will suffer from one symptom associated with a TMJ disorder throughout their lifetime. So when I say symptom, it's basically, we're not only talking about just pain, although pain is mainly the driving, I would say, a factor which has patients seek medical attention. But again, symptoms could also be anything that they feel in the entire neck, head, and facial region. It affects all genders and ages. However, it is more prevalent in females 20 to 40 years old. Symptoms may fluctuate over time and can be self-limiting. And only 5% of the population will seek treatment for their symptoms. And most of the patients that seek treatment usually see doctors. These are the ENTs maybe, and dentists who more than physical therapists. So actually, I just remember this conversation from one of the PTs when I was talking about the TMJ. But I asked a lot of PTs back home when I was when I was there 2 years ago. And asked them, okay, do they teach the TMJ in the BSPT program? I can tell you, I have had no exposure to the TMJ back when I was still in school, and I graduated in 1996. So our program didn't really talk about the TMJ at all. We knew that it was a part. It was a part of the head, not even part of the neck. And so one of the PTs said, well, it's the forgotten joint. Okay, so which is probably true at some point, at an extent. But when you say forgotten joint, it's a joint that exists, but probably not that we don't pay much attention to the TMJ because probably one of the reasons is it's a region that we don't treat. Okay, so that could be one of the reasons why everyone says it's a forgotten joint. And I forgot, I want to run that poll. Isabel, I think I gave you that first polling question, and I want to see that.
Yes, we'll post it in a bit. Paula just asking for help. Thank you.
All right, so looking at the percentage of responses here, we have more than 3/4 of the participants saying that they do not treat patients with TMJ disorders, which I probably expect as far as the number of it. But I can tell you, even in the United States, not very many PTs actually treat the TMJ. And I think it's just, the reason for that is really more of, training or postgraduate training in this region usually takes place in residency programs and fellowship programs. And so most of us who have been trained in OMPT have this as part of our competency. The only thing that probably I would comment on is a lot of fellows or a lot of postgraduate specialists in OMPT have training in the TMJ, but the question now is, do you actually see patients in the clinic having a TMJ disorder? Okay, not very many, again, have that exposure as far as the clinical side. We know of it in theory, but as far as the clinical setting, the exposure, we probably don't have many. And I think this is a specialized practice that I hope that at some point when we can offer a full a comprehensive line of courses for you in OMPT, that we have this as a standalone course, and which can be taken without any prerequisites. Again, I think having and it's just not a 2-day course. We can always expand this into a program where we can have some mentoring involved, especially for those PTs who are planning to build a practice, a direct access or autonomous practice, especially for those PTs who have, I would say, relationships with dentists out there or other medical specialists in orofacial pain. You could definitely build up a practice based on that, and you PT as a provider, we can get you that much training. So by definition, TMD or temporomandibular joint disorders is a subset of orofacial pain. So that probably also explains why that most patients who have pain in that region, don't think about seeing anybody else except maybe go to see an ENT or a dentist, because basically a lot of their pain is in that region. But again, as a physical therapist, this is part of our practice also, being able to navigate through a scenario where patients coming in with maybe neck pain or pain in the facial area, you would be, this is important because you need to do a good differential diagnosis of the entire region to determine where the pain source is at. And so as I discuss through the next few slides, you will see that the entire craniomandibular region is actually connected. So diagnosis is essential. In order to diagnose, we need to classify. So when we say classify, we need to group certain conditions affecting the craniomandibular region into specific subgroups. Okay, And again, this classification was first developed by the American Academy of Orofacial Pain. We call it AAOP. So this organization it's a professional organization dedicated to the research, treatment, and teaching of orofacial pain. They do a lot of. They have the academy, or the academy is a group of all specialists, and that also includes PTs. Okay, so you have doctors there, you have otolaryngologists and other clinicians involved in the treatment of orofacial pain. So the initial classification of TMJ disorders developed by the AAOP states that you'll have a classification of articular disorders. Okay, so articular means joint. So you'll have a condition that affects the joint, and also a condition that affects the disc. As we reviewed the anatomy of the TMJ in a bit, these are all the structures, anatomical structures of the articular of the joint. Now you also have masticatorial muscle disorders, so simply called muscles. Okay, and you'll have, because muscles can affect the TMJ, muscles can be painful, okay, as well as the joint can be painful. And you have another category or classification called arthralgia. Okay, arthralgia is again it could be a symptom. It is also a condition secondary to maybe an arthritic joint, OA, RA, pain, inflammation, and all the other and other conditions that affects the joint. Okay, and there is another classification that was originally not in the AAOP classification of TMJ disorders, but now it is recognized as one of them is cervical headache. Okay, so we over the years, over the studies, they found that a headache could contribute to symptoms in the face, in the oral, in the TMJ and orofacial region. There's a strong association of cervical headaches, okay, or I would say headaches to patients who are seeking medical attention because of symptoms in the facial region. Now, and we have also, as far as our differential diagnosis, we also want to know if a patient who comes to see us for a TMJ problem, we want to know if the problem is mechanical or if the problem was psychosocial. So, and I think this is part of this of the differential diagnosis in the psychosocial aspect was, I would say, was discussed by Dr. Hiroshi Kiyota earlier. Really, my colleague, dear friend. We were together in Japan for the Asian OMPT conference 2 years ago, and he also is an adjunct instructor again for physical therapy advancement seminars. And so, if you recall, the title of his presentation was Beyond Mechanistic Approach. Okay, so what do we do when a problem is non-mechanical? Okay, so when we go to the psychosocial aspect of it, we're talking about other factors, okay, that can contribute to the pain experience through a patient who is suffering from pain. Okay, psychosocial simply means there are psychological factors. Okay, so you have anything from depression, stress, okay, and things of that nature. So we want to look at our patient in the biopsychosocial aspect. Okay, so we want to look at the bio part, psych, and the social aspect. Although, again, I won't go through that. It's a different topic for another day. But again, it is something for us. We need to recognize a mechanical disorder or a psychosocial disorder. But again, these two groups actually overlap. Okay, for a patient who has pain beyond pain that is untreated, pain that lasts longer than and affects their daily function, it can actually progress into a psychosocial aspect. It can develop psychosocial issues. So a lot of those can again, these two can actually mix. Okay, so we need to know when to provide intervention for these groups. Okay, so the updated diagnostic classification was developed for actually for PTs now. So the group in University of Kentucky, led by Dr. Harrison, this is actually based from an article. I can share with you. I can share this with Dr. Lily after this presentation, and again, it's actually this one. It's called A Proposed Diagnostic Classification of Patients with Temporal Individual Disorders and Implications for the Physical Therapist. It's a really great clinical commentary by Harrison et al. Back in 2014. So this expands the classification of TMJ, craniomandibular disorders, which reflects our practice as a physical therapist. We need one classification is red identification of red or screening for red flags. Okay, so we know we always talk about red flag screening, which simply means we need to find out whether this patient is a candidate for PT. Would this patient benefit from PT or benefit from a different specialist? So we want to recognize through our systems review, and this should be part of our examination process. It should be part of our initial evaluation. We need to do a systems review, which includes all systems: cardiovascular, pulmonary, neurological, musculoskeletal, and all that stuff. So we want to look for signs of medical illness. Right. One of the conditions that would necessitate referral again to a specialist, or maybe referral to the rehabilitation team, when we say, which also means that we need to be part of that process in managing patients, is for our patients who are exhibiting with a headache. Okay, because headaches can actually affect the entire region. Okay, so headache, whether it's an occipital headache, temporal headache, or headache from the upper cervical spine. Okay, so primary headaches could include, we call migraine headaches and tension type headaches. So these are types of headaches that have a vascular and neurological origin. We also want to know how to screen for CNS lesions. Okay, so central nervous system lesions, and this could also be all the neuropathic pain is one of our CNS lesions. If you probably recall a condition called trigeminal neuralgia, that would be considered a CNS lesion, and it also again can contribute if you recall through our medical surgical courses back in PT school. Trigeminal neuralgia affects the trigeminal nerve and can actually present with pain in the facial area. Okay, it can present with headache, with jaw pain, and it can also present as a neck pain. So everything, it affects the entire the region where the trigeminal nerve supplies. Now, for this, identification of red flags or screening for red flags need to be part of our initial evaluation. Now, I know because of our practice back in the Philippines, we rely mainly on the rehab medicine doctors to make this determination. But again, as a PT, who is working towards autonomy, Okay, we need to know how to do a good systems review and screen for serious medical illness. So this classification 1, there are two other classifications that was developed by Harrison. Classification 1 involves the joint. Okay, so involves the joint, the disc, the muscle, and it also can include capsular disorders and also a cervical headache contribution. So take note that the headache that we're referring to in classification 1 would be a headache from the cervical spine. So we need to know how to do or screen and do our differential diagnosis through our assessment, through our patient interviews to determine whether their symptoms are have a cervical spine contribution. So that when we also have classification 2, which is again the identification of psychosocial stressors. Okay, and these could be patients who are coming in with chronic pain. A lot of these need to be dealt with through a team approach or referral to for counseling. Okay, so we go a little bit